So hi everyone, I'm here with GU Oncology now, and my name is Jordan Ciuro, and I'm an assistant professor of medicine at Winship Cancer Institute of Emory University. And it's a great pleasure to introduce my colleague and friend, Dr. Bilen, who's an associate professor of medicine and director of our GU Oncology medical program. And I'd also like to welcome Dr. Gerke, who is our aspiring medical student at Emory. So thank you both for joining.
Thank you so much for having us, Jordan.
Thank you for the opportunity to be here today.
Of course, happy you can make it. So today we'll be reviewing lutetium therapy and metastatic CRPC, as well as highlighting our GU ASCO 2025 abstract, which we have collaborated on, which is looking at real-world outcomes of lutetium in a racially diverse cohort of patients with metastatic CRPC. Before we dive deep into the abstract and our results, I would like to spend a few minutes answering the question of what is lutetium and what trials led to its approval. So lutetium is a radionucleotide which binds to PSMA, also known as prostate-specific membrane antigen, and it causes beta particle emission, which basically leads to DNA damage and cell death. It is given every 6 weeks, and it's also approved for 6 injections. And some side effects include xerostomia, myelosuppression, as well as fatigue. When you're looking at the trials, the VISION trial was the first trial to evaluate lutetium in metastatic CRPC in patients previously treated with an ARPI as well as at least one taxane. Patients did require to have uptake on PSMA PET imaging, which was defined as increased uptake greater than the liver, and they were randomized 2-to-1 to either lutetium or protocol-permitted standard of care, which actually excluded chemotherapy, immunotherapy, radium, or any investigational drugs. So, results from the study back in 2021 in the VISION trial did show that there was an improvement in PFS from 3.4 months to 8.7 months, as well as an overall survival, which improved from 11.3 to 15.3 months in those receiving lutetium. And when we switch gears and look at the therapy trial, this was actually completed and presented at ASCO 2022. The schema, as you'll see on the slides, it did have a different patient selection. And here, patients with metastatic CRPC, to be eligible, they required PSMA uptake with an SUV max actually greater than 20, so not only greater than the liver, and no discordant PSMA disease. They were randomized 1-to-1 to either lutetium or chemotherapy with, at the time, it was cabazitaxel, which follows our standard of care protocol in real practice. And in this trial, it was found that lutetium delayed PFS when compared to cabazitaxel therapy. But interestingly, when you looked at the overall survival and the intention to treat patient population, there actually was no difference. So looking at vision and therapy trials, and these are both pivotal in establishing Pluvicto as an important treatment option for patients with metastatic CRPC with PSMA positive disease, and therefore leading to its approval and incorporation into clinical practice after patients fail both chemotherapy as well as an ARSI. So, Dr. Bilen, seeing this data, the first question I'd like to propose to you is if you could summarize who in your practice you think are ideal candidates for lutetium therapy.
Thank you so much, Dr. Ciuro. It was a great summary. And as you know, this is a very hot topic in prostate cancer, radioligand therapy. I think we are all looking for novel MOAs, and now we're able to use lutetium PSMA for our patients with advanced metastatic prostate cancer. I currently use lutetium PSMA based on our NCCN guideline for patients mCRPC, fail novel hormonal agent and taxane-based chemotherapy. And we also changed the mechanism of action from oral agents to chemotherapy. And I think PSMA RLT is a nice addition to our therapy algorithm. Because of this reason, I used before cabazitaxel. But we also have some patients doesn't want to get chemo or couldn't get chemo. Because of that reason, we may use lutetium little early. Like PSMA-4, like a population. But on the other hand, some of our patients cannot get radioligand therapy due to some difficulty for isolation or access of care. And if that's the case, we may not able to use lutetium PSMA. But currently, I will go with NCCN guideline.
Very well said, Dr. Bilen. I completely agree. In my practice, I'm really utilizing lutetium in patients failing a taxane and an ARPI. However, there are some patients that perhaps, they decline chemotherapy, or perhaps they actually cannot even receive Pluvicto given maybe their location where, the Pluvicto might not be a therapy, or they don't want to follow the protocol, or, which requires actually isolation. So great points. So moving forward, seeing these results, it does raise a question if these outcomes are consistent in a diverse or real world patient population. And, when you look at the baseline patient demographics in the VISION trial, which I have included for review, you can see that the majority of patients were actually white in both arms, with only about 7% being Black or African American. So extremely underrepresentation in this trial. With this question, we decided as a team to do a retrospective analysis on real-world outcomes in patients receiving lutetium-based therapy here at Emory. And Dr. Gerke, would you like to give a summary of our study as well as the results?
Yeah, thank you so much for the opportunity to share our findings. I really think it's critical to examine real-world outcomes in diverse patient populations, especially given the notable racial disparities that are seen within prostate cancer. So according to the American Cancer Society, the average annual incidence rate of prostate cancer is 73% higher in Black men than in white men, and Black men are nearly twice as likely to die from prostate cancer compared to their white counterparts. In our study, retrospective analysis was conducted, including a real-world sample of 84 patients with metastatic castration-resistant prostate cancer treated with lutetium PSMA-617. Our primary endpoints were progression-free survival, overall survival, and a PSA 50 response. In our cohort, 47.6% of patients identified as white and 42.9% self-identified as Black. The overall cohort had a 12-month survival of 84.4%, which was not significantly different between Black and white cohorts. The median progression-free survival in the overall cohort was 6 months, which was not significantly different between the cohort subsets. The 12-month progression-free survival was 41.9% without differences observed between subsets again. 50% of the overall cohort had a PSA 50 response, which was similar between cohorts, with 56.1% of the non-white cohort having a PSA 50 response and 43.9% of the white cohort having a PSA 50 response. So, with similar progression-free survival, overall survival, and PSA 50 responses, in this racially diverse cohort of patients with metastatic castration-resistant prostate cancer, our results demonstrate lutetium PSMA-617 effectiveness in a real-world population.
Yeah, that's excellent. No, thank you so much, Dr. Gerke, for working with us and actually putting together this real-world study. Reviewing this, obviously there are issues with real world data. It's not a perfect science. I guess I have to say, what do you think are some limitations of real world data? And are you surprised by the study analysis that we did?
Yeah, definitely real world data lacks the control that a randomized clinical trial would offer, but it does offer valuable insights into diverse patient populations. So given the underrepresentation of non-white patients within the VISION and the therapy trials, our results, which align with similar overall survival and progression-free survival, certainly reinforce confidence in using this regimen for non-white patients outside of a trial setting.
That's fantastic. I couldn't agree more. Real world data, by no means is perfect, but unfortunately, sometimes it's the best data that we have. And I think we have to utilize this data to really see how this data might hint it might affect our patients in the real world setting. So thank you. So now I've included, some questions here for Dr. Bilen for further discussion. Dr. Bilen, reviewing these results, I guess my second question is really what initiatives should we as physicians implement to overcome healthcare disparities and improve representation of diverse patient populations onto clinical trials?
No, Dr. Ciuro, I think that's very, very important. First of all, I want to congratulate Dr. Gerke for her effort. When we see our young generations doing research early on, I think it's very, very important for academic medicine. Yeah, Margo is our student, doing research, and she started this project from the beginning all the way to the end. And I can tell her future is bright, which is really, really fun to watch. In terms of your question, Jordan, I think this is a very, very important priority for us. At Emory, we try to enroll diverse patients in clinical trial because we wanna match our clinical trial population to our clinic population, and we don't want to see a big like a disparity for our clinical trial population, because that's very important for biomarker discovery. That's very important to apply the trial result to real world. Because of this reason, I think we need to work as a group. But we need a broader effort. We need to do outreach, education, partnership with key stakeholders, community organization, advocacy group. And as a group, as a field, as a community, we need to keep enrolling diverse patient in our trial. I think that's the only way we will solve this problem.
I couldn't have said it better, Dr. Bilen. I feel like as a community as a whole, we need to do better. And I know at Emory, this is a top priority for us. So I'm very grateful to be working with all of you. My second question here is, what are the biggest gaps in current research regarding lutetium-based therapy?
No, another very important question, Jordan. It's a new drug that bring a lot of excitement to us, but also bring a lot of opportunities to us. As Margo highlighted, we need biomarkers to identify who should receive this medication, what will be the outcome and prognosis of those patients who receive lutetium PSMA therapy. I think we clearly need an easy, reproducible biomarker that we can apply to clinical practice. And also, as I mentioned earlier, is a new drug, it changed our therapy sequencing. What will be the ideal sequence? What should be the treatment A and then B and then C? We need to do a more clinical trial to answer sequencing. And we also have some studies that may bring lutetium PSMA early on, including metastatic hormone-sensitive prostate cancer. At that time, we're going to ask the question should we doublet, should we triplet, should we do triplet with RLT or chemotherapy? Those are very, very important questions that we need to answer in a prospective manner with a biomarker support. And lastly, we are in a combination era. We also use lutetium PSMA with other combinations, including immuno-oncology, targeted therapy, because ultimately we want to cure our patient and we want to make their outcome as best as possible. Because of this reason, I think in the near future, we're going to see a lot of combination trials come to our doorsteps in prostate cancer.
I think it's a very, very exciting time for prostate cancer research. And, I'll be interested to see the data of, really moving lutetium-based therapy up front. And again, we're all hoping for cure. So very, very exciting time. So in summary, Vision and Therapy trial did show efficacy of lutetium and metastatic CRPC. This is well known now. And we as a group have displayed real-world outcomes showing overall survival and PFS improvement in a racially diverse patient population here at Emory. And we need more research to identify, like Dr. Bilen had mentioned, biomarkers to help us predict response as well as the best sequencing of therapy. And to finish off, I have included a list here of some very exciting trials of lutetium-based therapy for our audience to review at a later time. And with that, I'd like to conclude our chat today. Thank you both for joining us on GU Oncology Now, and I hope to talk to everybody soon. So thank you.
Thank you so much again for having us.
Thank you so much.